ahead.
Yeah.
Okay. Let me see. Wait. Mm, Where can I share the screen?
In the bottom, there's a share button.
No, not here. Oh yeah, now I have it. Okay, no problem. Good. So how much time do we have? I will hurry up a little bit. Do you
15
see
minutes.
my
15
screen?
minutes. 15 minutes.
15 minutes. Okay, so I will skip a couple of my slides. Yeah, thank you. Thank you for the invitation, and it's a very interesting topic. And I will try to convince you that we don't do arthroplasty anymore. Um, yeah, I'm in India actually, Sandeep, and yeah, I was a little late today. Okay. Well, I have to disclose a couple of companies, but this is unrelated to my talk, and I dedicate this talk to my teacher, Dr. Gab. He just died after Christmas, and I was at his funeral 2 days ago. So yeah, not very old, 77 years, but not much famous for spine, more famous for brain endoscopy. Okay, I will just go ahead. This is where I work at, Southwest Germany. 1 hour from Frankfurt, but right now, as I said, I'm in India. This is our department at the university campus. If want to, you can visit us anytime. The department was actually quite famous for minimally invasive procedures, and particularly also for cervical procedures. So the Caspar used to work here, and all his developments were done in this hospital. The topic of my talk is when to do ACDF and what is the long-term results, and when to do cervical disc arthroplasty. And the ACDF is a much older procedure. It's well known for 50 years, more than 50 years, and the arthroplasty is on the market, I think, about 30 years. So there's some difference. Here you see the timeline. So ACDF is an old procedure, 70 years now, and the arthroplasty is a little bit a little bit more than 30 years. Anyway, what are the indications? So I think a general consensus is that we have a multi-level cervical disc disease with severe osteophytic changes. Probably would rather go for fusion and for an ACDF. If you have a single symptomatic cervical disc disease with not much joint arthroplasty, arthropathy, and not much osteophytic changes, probably we would rather consider an arthroplasty. And in general, the younger the patient, the more happy we are to apply an arthroplastic procedure. The surgical strategy, I think I just skipped this. I have a couple of videos. It's not, this is a typical case where we did an arthroplasty. You see here single level disease. When you look at the other levels, there's not much degeneration, and patient had a clear radicular symptoms. 43-year-old, so I think it's a good case for arthroplasty. I think I skipped well, maybe one video. One video, I will forward a little bit. You see, there are so many different ideas how to do arthroplasty. Actually, I always take the ligament. I always do right and left oncoforaminectomy to decompress the nerve roots. So I'm rather intense in the decompression. And then the placement of the disc, I think I'm very careful to put it right in the center, in the midline, and deep enough that it's really in the center, the motion segment. It's basically not different from the ACDF procedures. And this is here the example we just saw with the arthroplasty. Case 2, I will skip. It's a 2-level arthroplasty. Case 3, this is a case where we typically do an ACDF. It's a 66-year-old female. You see here on the right the cervical myelopathic changes with the signal intensity in the T2, huge disc prolapse, and not much degeneration, but because of the signal intensity, and I'm always very reluctant to put an arthroplasty in a myelopathic spinal cord. But it's possible. There are people who do differently. And this is here the case where we then put in the cage and the plate. And here you see the post-operative MRI and X-ray. Another case where we actually did the combination of both. You see here there's a severe ossific severe degenerative changes 5, 6, 6, 7, and the disc prolapse at 4, 5, where the disc actually does not look that bad. So this was a case where actually we ended up, those are rare, we haven't done that many. We ended up doing an arthroplasty and then a 2-level ACDF. So this is the post-op. So now when we have now experienced the procedures, what is the outcome of these techniques? And then you can look at the meta-analysis, and actually the results are quite diverging. There are very good results on ACDF. There are very good results on the disc arthroplasty, and our own results. We just we analyze, and I will present them to you now. The ACDF has a high fusion rate, and always it's considered to be more in danger of developing a symptomatic adjacent segment disease due to the altered biomechanics. Arthroplasty should maintain segmental motion, and we hope that we have lower incidence of symptomatic as adjacent segment disease because we reduce the adjacent segment degeneration. Well, what is the long-term evidence? And actually, we have analyzed our procedures. We have analyzed the arthroplasty cases and the ACDF cases. And I will just show you now those results. And they are, for me, they were quite surprising and, well, good for my talk because the ACDF results are so good. So these are the two cohorts, the ACDF cohort, and the arthroplasty cohort. It's a long-term follow-up, and these are the results at the latest follow-up. The mean follow-up and the ACDF group was 25 years, so it's a very long follow-up. Minimum follow-up was 17 years. And actually, when you look at the quality of life in the questionnaire, the level 1 mobility was achieved in 90%. Level 1 self-care, no problems, 93%. Usual activities maintenance, 85%. No pain and no discomfort, 92%, and no depression, 95%. So excellent results with this ACDF. So then arthroplasty, actually the cohort is a little bit smaller. I will get back to this later. And the mean follow-up was 15 years, and the minimum follow-up was 9.5 years. But you see here, mobility, I have no problems walking, less favorable. The self-care is similar. Usual activities level 1, it's less, I think it's related to the mobility. It's only 68, and pain and discomfort, I have no pain only in 50% of the cases. And depression, 71 were no anxious and no depressed. So when we look at the quality of life questionnaire, you can always criticize this questionnaire, but you see that at least in our cohort, those two groups, they had diverging results. Then we looked at the final follow-up outcome, and you see here, this is this in the ACDF group, free of radicular pain. It's 90% of the cases, and then repeat procedure due to degenerative cervical disc disease in 10.7%, and symptomatic and adjacent segment disease with repeat procedure in 7.4%. When we compare this with the arthroplasty, you see at the final follow-up, 9 to 15 years, we have no sensor deficit in 60%, no arm pain in 70%, no neck pain only in 50%, and no gait disturbances in 90%, and no motor weakness in 95%. So to bring this together, so what is the comparison? Quality of life, arthroplasty has less favorable results in our cohort. Otherwise, the self-care level is similar. Daily activities is less favorable with arthroplasty. Pain is less favorable with arthroplasty, and anxiety is less favorable with arthroplasty. Then free of radicular pain, arthroplasty is less cohort, less group of patients with favorable radicular pain results. Sensory deficit, there's not that much big difference, 15%. Motor deficits very similar. Repeat procedure, and then this is surprising, and you see the repeat procedure was 10% in the ACDF and 17% in the arthroplasty. And a repeat procedure for symptomatic adjacent segment disease, even this one was higher in the arthroplasty group than in the ACDF group. So when we summarize our results, there's a higher rate of mobility. Level 1 results in ACDF, higher rate, favorable, better results with daily activities of level 1 in the quality of life assessment in ACDF. Higher rate, higher percentage of pain-free patients in ACDF group, less repeat procedures with ACDF, and same number of repeat procedure for symptomatic adjacent segment disease, 7.4 to 8.6. What are the limits of this comparison? Of course, it's a retrospective analysis. The follow-up is different. The group size is different. So the ACDF group was 122 patients. The arthroplasty long-term follow-up was only 68. And the minimum follow-up was 17 years to 9 years. But what can we conclude? Well, I think ACDF gives at least extremely favorable results in the long term. And at least in our group, it gives superior long-term results in comparison with the arthroplasty. And the expected superiority of arthroplasty in reducing symptomatic adjacent segment disease was not seen. And based on these data, there's no evidence for any superior arthroplasty results. So ACDF, based on our data, should be the procedure of choice. These are the papers where actually I refer to. There's those 4 papers you can look at in the PubMed. And if you are interested to see how we do ACDF, then you can come here for the our spine workshop, and this is going to be in May. And then we have our endoscopy week in September. This year, the endoscopy week is in conjunction with the International Federation of Neuroendoscopy World Meeting in Austria. So if you book one of our models, you get an extra discount to continue with the World Meeting right after our endoscopy week. And if you're interested, you can now use this QR code, but this is for the spine instrumentation. Thank you for listening. So, Mehmet, are you there? I don't hear anybody.
Yeah. Yeah.
So, Joachim, so you said that in your center, the results of ACDF was far superior to
Yes.
arthroplasty. The only odd thing I was seeing in your first slide when you were comparing the two, as far as depression was concerned, only 4% of your patients with ACDF were depressed, while 28% of the patients with disc arthroplasty were depressed. Could that be a
Yeah,
reason for
well,
very?
I think, in my opinion, now I have a bad, no, in my opinion, the difference is that the group of ACDF, they received earlier surgery. So I think that it's just that the situation, and the general situation of the population was different, and then this is the at the final follow-up, this is the quality of life questionnaire. They just have to sign and mark what their feeling is. And I think the ACDF group, were just in general more positive also towards the results of their surgery than the disc arthroplasty group. But actually, to be honest, I have the same feeling. And I mean, I have I still do some arthroplasty. It's not that we don't do. And I'm myself, if I had an MRI and I don't see anything else, I would go for a disc replacement. I would go for arthroplasty. But yeah, but when you look at the data, actually, it's not much support for this to continue with arthroplasty. And actually, I think the reason is that the ACDF gives extremely favorable results, and the role of motion preservation in C5667, which is about 90% or 85% of the ACDF, and the disc arthroplasty is not that important. I think this is the reason. Yeah.
And Joachim, you also said that the adjacent segment disease is similar in both groups, is it?
Yeah, what we counted is actually you can look the paper up. The paper is on MRI changes on the arthroplasty. And the paper is quite interesting because there's absolutely no difference in MRI adjacent segment degeneration than with the ACDF group. So they are exactly the same. So it didn't give any benefit to use arthroplasty for the degeneration. But degeneration doesn't mean much. So what I presented to you now is only the cases who underwent a repeat procedure in the adjacent segment. So symptomatic adjacent segment disease, meaning so symptomatic that they needed surgery in the adjacent segment. And this is exactly the same number in both groups.
What do you think? Okay. Are there questions probably from the participants?
Joachim, I'm really astonished by this data, your results, which I mean, is this a single surgeon experience? Are different surgeons involved, different implants involved? I mean, we need more data to value your results.
So this is the results of one department with including all surgeons who did the cases.
And different devices.
It's not a single surgeon, and none of the people who evaluated this it's actually double blinded for the
Right.
for the MRI. It's
But
not blinded for the
different,
patient. For the patient, you cannot blind it. I mean, if you ask the
of course,
patient,
of course.
how do you feel? Then he says, but and none of the people who did this evaluation were involved in the cases. No surgery was done by one of us.
But are you talking about different devices, different arthroplasty devices?
There were two different
sets,
devices.
different levels, multi-level, single level.
All levels were included.
So
Yeah.
it's a real world experience.
Yeah, it's just all we could find with a follow-up of more than 9.5.
Right,
So
right.
basically a minimum follow-up of 10 years.
So if you don't find a surgeon in your country, if you have a disc, come to me. Arthroplasty.
Joachim,
I hope not. I hope
I
not.
think, Joachim, I think that the results might have been skewed a bit by just the fact that by and large the fusion patients are older and that has got a longer follow-up. So they were of an older generation as compared to the arthroplasty patients who are of a younger generation, and the current generation is more difficult to please. And
I mean, there are definitely a lot of influential factors. I mean,
Yeah.
definitely. I agree with
Absolutely,
you that
absolutely.
probably when you go back, I mean, this is a different generation, the population. So when you have a mean follow-up of 25 years or 11 years, that means that the patients minimum are probably 14, 15 years older. So that means that they were back then probably less reluctant to, more reluctant to surgery. So there was more severe pain, and it's easier to please them. Might be, might be.
Yeah, actually, the depression data was very striking, 28% versus 4%. So if you are 28% patients are depressed, they will say no to everything. And
Well,
then
I
when you ask
think
about demobility
this
or
is,
anything, so
yeah, I think this is much better now because in the beginning, when we started with arthroplasty, I mean, this is, this is, when we started with arthroplasty, we were not aware that if you have even mild facet degeneration, these patients, they remain with neck pain. And I very, very rigidly, I just cut them out. And this makes the results, the average results, much better. But in the beginning, we did not know. I mean, we did the same as they did. As I said, these are not cases we treated. We came here about 14 years ago. So, and this study is already published like 4 or 5 years ago. So none of these patients underwent surgery by one of us. But I assume that this is one of the reasons. And we really try to avoid, if they have facet problems, then I think fusion is a much better option.
Joachim,
Yeah.
28% depression sounds like a result from Greenland, not from south of Germany. I don't know why you have this much depression there. You have a lot of sun.
No, it's not depression. I mean, it's not depression is different gradings. It's that they feel not scared. I mean, there's this 3 level of the quality of life questionnaire. It does not mean that they are in treatment. You have to go back to it's not that this is depression in the criteria of a psychiatrist. Not that we get the wrong impression. This is only the uh, the quality of life questionnaire with 1, 2, 3 levels. And the level 1 means that you're not depressed, you're not anxious. And there were more people in this level 1 being not anxious at all than in the arthroplasty group. Okay. In the arthroplasty group, there were a level 2, and when I put level 2 and level 1 together, I have the same 95%. Level 2 is I'm moderately anxious. None of them was under treatment. Not that you really think it's depression by a psychiatric definition, not at all.
Yeah.
But of course, I mean, my duty was to give you the best results of ACDF, and so I picked what I wanted to show you.
Good.
There's a little bias
Yeah.
in interpreting the results.
Just a little
I,
bias.
I did that unintentionally. Actually, I didn't know that you have done such a study.
You did not? I thought that's the reason why I got them. That's funny.
Yeah, this is funny. Yeah.
I thought you knew that.
You know what? There is one point that for the arthroplasty, as I know from the literature, more than one level arthroplasty results are better than one level arthroplasty results. Probably this is another issue that more than one level arthroplasty provide more mobility preservation than one level. What do you comment about this, Oscar? What is the reason of
No,
that?
that's absolutely right. You are absolutely right. And if I look back to my practice since 2008, when I start to do a lot of arthroplasties instead of fusion, I always privilege patients with multiple levels. Those are the ones. That was my bias. That's why I have many patients on my cohorts with multi levels, because at least you are right. One level, you don't see the difference.
Right.
You see the difference between ACDF and arthroplasty if you do more levels or if you follow up the patients longer. That's my impression.
Another point is that there are level 1 and level 2 prospective randomized trials, which was published by Arthroplasty. They are perfect and the outcomes are better. But there is a big critic that all these trials were done by these people who are using arthroplasty devices regularly, not by independent researchers.
Well, I did not point it out too much on the surgical technique, but I think arthroplasty is much more difficult with patient selection and the procedure. ACDF, if you have a nice cage and you do a distraction, in probably 90% is already done just by distracting the vertebral bodies. You don't have to do a very, very good decompression, oncoforaminectomy, you know, everything is decompressed because it's fused then. So I think it's from the perspective that to have a successful procedure, although it's more manipulation when you think about it, I think it's the easier procedure. Patient selection is easier and the procedure itself is easier. I think arthroplasty is more difficult, particularly in patient selection is more difficult. And then you have to really look that it's in the center. I mean, the implant position, to me at least, it matters much more. So if you don't do much, then, and you do like 5 arthroplasty and 5 ACDF in a year, probably these 5 ACDF have better results than 5 arthroplasty because you need more experience, in my opinion. Although this is not very obvious when you just look at the technique, but I think it's more difficult to find the ideal candidate.
Absolutely. I think on ACDF, you can rely on indirect decompression. There is no way you can rely on indirect
That's exactly
decompression.
my meaning.
And that's the criticism about this study that you showed, because you have a long-term follow-up, many years, and the numbers for arthroplasty are small. This is less than 6 cases a year in the study.
Oh, no, it's not then less than 6 cases a year. It's 68 with more than 10 years.
Right. Which means that the time they were operated, it's 6 cases a year.
No. 10 to 15 years. And it means that you have, there were a lot lost.
Okay.
You know, this is, you have of this group,
But
over 6 years, you have 10 per year where you have the final follow-up.
okay, so what was the loss to follow-up rate?
The loss to follow-up rate was very high in both groups. I don't remember. It's 2/3 or something.
Right.
Very high.
Very high.
I mean, this is the always what you do when you do have long-term follow-up, very long-term, you just lose these patients.
Absolutely.
Yeah.
I think it was a pretty good webinar, and I think we should wrap it up now. We had a pretty nice discussion. I don't see any questions there from the audience right now.
There is one last question, actually.
That has already been addressed.
Addressed, yes, right.
Yeah. So.
Okay, guys, thank you for waiting for me.
It works that we waited you.
You gave us enough time to chat amongst ourselves.
Okay. Well, see you soon, huh?
Okay. Bye-bye.
Okay, bye-bye.
Thank you. Thank you for inviting.
Thank you all for coming and for making very, very nice talks. Thank you.
Okay, thank you, Mehmet, Oscar, Sandeep, bye-bye.
Salam alaikum.
Goodbye.